Hello. My name is Malcolm Walker. I'm Professor of Clinical Cardiology at University College Hospital, London. Thank you to the organisers for inviting me to speak at this conference. My only regret is that I can't be with you in person. I've been asked to address this particular question: can we prevent today's cancer patient from becoming tomorrow's heart failure victim? And that this begins with a good story, the story that victims of cancer can now expect to survive much longer than in the past, so that 50% of adults with cancer can be expected to live more than 10 years after that diagnosis. The figures have been even better for childhood cancers, with more than 80% of children surviving more than 10 years. And with this graphic on the left of your slide, you'll see the progress in survival for a whole series of different childhood cancers, with some achieving 100% survival over decades. With this good story comes some consequences, and those consequences for cardiovascular disease. There are increasing numbers of cancer survivors seen with heart failure, and some estimates suggest that maybe up to 5 to 10% of heart failure presentations may relate to previous cancer chemotherapy. The two prime culprits here, if you like, are a group of commonly used anti-cancer therapies, the anthracyclines, as well as radiotherapy. However, newer anti-cancer therapies and combination therapies are bringing their own unique problems and complications. Some of the mechanisms involved in the toxicity that is seen clinically are as yet incompletely defined or understood. And that means that cardiovascular strategies to deal with them are necessarily ad hoc and not necessarily based on tremendously good evidence. The number of prospective trials is relatively few, and the number of patients involved in these trials are generally small. And I would contend that in order to deal with this growing problem, we're going to need new approaches in order to optimize what the cancer doctors have been able to achieve. This is a slide of what happens to women with who survive breast cancer. And you will see after about 10 years, here I've highlighted in red, that the deaths due to cardiovascular disease begin to exceed those due to recurrence of the breast cancer or the development of other cancers. And the effects of cancer therapies are legion, multiple effects on different parts of the cardiovascular system. On the right is a cartoon that I'm not going to go through in detail, which illustrates the various mechanisms. And we can think of these in terms of very acute effects with myocyte damage and the production of acute heart failure, as we might see with anthracycline exposure. And we can see here with the anthracyclines attacking myocytes. Ischemic vascular events, arrhythmias, coronary disease, thromboembolic, both venous and arterial, as well as hypertension and general deconditioning are all factors that can occur acutely on exposure to cancer therapies. There are some chronic effects also, and these may have very long latencies, including ventricular dysfunction, the development of chronic heart failure, a DCM-type phenotype with low ejection fraction. Or indeed, we're increasingly seeing individuals with heart failure with preserved ejection fraction. One of the features, but perhaps particularly of radiotherapy, is the capacity to accelerate underlying propensity to arteriosclerosis, increasing the risk of acute heart attack, strokes, and peripheral vascular disease later down the line. Patients who have survived cancers have a higher incidence of cardiovascular disease than their peer-matched group who haven't had cancers. There are long-term changes in vascular function which lead, in some following the acute hypertension, to more established long-term problems with blood pressure. There may be profound autonomic changes that are associated with significant exercise limitation and symptoms, and these can be very problematic clinically. And again, long-term deconditioning is in there as a factor. And you can see here the various different forms of therapy with the various targets that we might associate with them. Just to go back to children, 80% cancer survival rate, which is fantastic. This graph here shows us the Z score for cardiovascular function assessed in this study by left ventricular contractility, a stress velocity index from echocardiography. And at the end here, the beginning of this green column, at the end of chemotherapy with anthracyclines, the mean cardiac function, as you'll see from the blue curve, is low. But over 4 years or so returns towards normal. And then there's a latent period of a number of years when ventricular function is normal, but after a 10 or 11-year period, you will see there's a dip in cardiac function as it begins to fall off in later years. And we understand quite a lot about this, and anthracyclines have been amongst the best studies cancer therapies and their effect on the heart. One of the prime mechanisms of anthracycline toxicity is binding to topoisomerase, to binding to the 2-beta isoform found in cardiac myocytes, and that interferes with normal metabolic function of mitochondria, which then function abnormally. It tends to precipitate the production of free radicals and reactive oxygen species, and is associated with breaking of DNA double strands. And you end up with cardiomyocytes that are vacuolated, with a derangement of the microfibrillar apparatus. We know quite a lot of the factors behind cardiotoxicity. The dose and type of anthracycline is important. There is a very strong dose-response relationship. So for doxorubicin, generally, although there probably is no safe dose, generally cardiotoxicity is assumed to occur after about 400 milligram per meter squared. And you can see some of the other forms of anthracyclines have different dose exposure limits. There's greater toxicity in young myocytes. Children are not small adults. The metabolism is different. And the very elderly also are more subject to anthracycline cardiotoxicity. There are distinctive mechanisms between the acute form and the more chronic form of cardiac toxicity, the latter having a lot to do with the chronic buildup of doxazosin and other anthracycline metabolites, which cannot be excreted from the myocyte. There's also a greater toxicity when you associate therapy in people with other cardiovascular risk factors. And here we see that if you have hypertension, then you have about a 1.5 times increased hazard ratio, which doubles if you have coronary disease or if you're elderly. But if you have all three, the increase in potential risk of cardiotoxicity is 5 to 6-fold. And here on the right, you'll see the risk of a serious cardiovascular event associated with survivors of bone marrow transplantation goes up for ischemic problems or cardiomyopathies or stroke, goes up with associated other standard, if you like, cardiovascular risk factors. When it comes to heart failure, this is a big problem in all health systems. For the UK, it costs our National Health Service about £1.8 billion, that's 2.3 billion US dollars per annum. 7% of the elderly population may be affected, and this is very difficult to be certain, but it's estimated somewhere between 30 to 60,000 cases per annum relate to previous cancer treatment. We've known about this for quite some time. This is a relatively old study. It's looking at women with breast cancer who have received anthracyclines, and generally, at least in current terms, the doses tend to be modest compared to certain other cancers. And you can see here the incidence, the risk of developing heart failure increases. The green you'll see here is a combination of HER2-targeted therapies, trastuzumab, in association with anthracyclines. The anthracyclines alone here, the blue curve, is above a normal person, but relatively modest over, in this study, a 5-year observation period. So we associate the late cardiotoxic effects of previous exposure to anthracycline, especially when it's combined with HER2-targeted therapies. So again, putting this another way, the risk here of heart failure in the years after treatment, at 5 years, about 4%, somewhat higher, I should say, than a normal population. Once you add in the HER2 receptor therapies, trastuzumab or pertuzumab, you will see that this goes up to quite a significant 12%. Some of the mechanism are understood and relate to the dimerization of the HER2 receptor. And when that occurs, then some of the beneficial hormonal protective mechanisms of the heart are inhibited. And that means that you end up with increased oxidative stress. So that when you add in something like an anthracycline that produces oxidative stress, its effect is amplified if this HER2 dimerization has occurred, and you end up down this cascade with, at the end of it, heart failure. But you can see here a very significant 20% incidence at 5 years. So this is a complex, and I'm not expecting you to take this all in one, but it basically gives you an idea with the different examples of chemotherapy classes of drugs and what you might expect, what we might know of the mechanisms, and what clinical issues we might encounter, and something about the mechanism that we know of so far. All these tend to be very generalized statements. So the anthracyclines inhibit DNA synthesis, they bind to 2-beta topoisomerase, they interfere with AMPK, and there are other potential mechanisms. Common drugs like methotrexate and 5-SU, again, inhibit DNA synthesis. You end up mostly with a phenotype of arrhythmia, ischemia, myocarditis, and the microtubule agents. And you go through this group seeing various different forms of cardiac toxicity to be encountered. I'm just going to talk a little bit about the tyrosine kinase inhibitors, both the monoclonal forms and the small molecules. And these essentially target the VEGF receptors and therefore have a very profound effect on vascular, arterial and venous. Hypertension, heart failure perhaps generated by hypertension, arterial and venous thromboembolism are the typical toxicities that one might encounter. Slightly different with the smaller molecules. And you might say, this is the FDA shared warnings for TKIs with the various complications you might see. And you'll see that hypertension, all of the FDA-approved TKIs have a warning about hypertension. Most have a warning about thromboembolic, arterial thromboembolic events. Most have a warning about cardiac dysfunction. So why on earth do oncologists persist in using these drugs? And they will continue to do so. And the reason is this. If you look here, this is chronic myeloid leukemia, which some years ago, this is the survival curve, or the lack of survival curve, I should say. And historically, only 15% of people with this diagnosis were alive at 18 months. And now you see what has happened as soon as the TKIs, the small molecule, and the monoclonals come in. You can see now you're looking at an 89% or greater survival at 18 months. So these drugs are fantastically successful oncologically, but that raises a problem for us. With problems come opportunities, and this is just a little illustration which I think is very interesting. This shows these particular drugs, but also here dasatinib, which has a very wide spectrum of isoforms of TKI which are affected by this drug. And interestingly, amongst them is this particular form of TKI, which has been associated with idiopathic pulmonary arterial hypertension. And guess what? This particular drug, which affects this isoform, also has a side effect of pulmonary arterial hypertension. So once we know the targets of these very precise drugs, we can get insight into the types of complication that might be seen in the future, but also it gives us insight perhaps for future potential therapeutic approaches in conditions which currently are very poorly treated, like idiopathic PAH. The simpler and the more common manifestation of systemic hypertension, this may occur within days of exhibiting these drugs, and the risk varies according to which molecule is used. And we tend to use ACE inhibitors because drugs like verapamil, diltiazem tend to induce cytochrome P, and that can increase the levels of these drugs very, very significantly. Now, this is important because there are many patients out there with hypertension who then develop cancer who may be on these drugs, and that can cause very severe interactions if it's not known about. I'm also going to just address very briefly some particular issues with regard to immunotherapy. The immune checkpoint inhibitors, relatively recent drugs such as nivolumab and ipilimumab, have also had a very important role to play. Acute heart failure, myocarditis is mentioned, and the mechanisms, I have to say, remain obscure. These drugs hit the headlines, and you can see why. In complex metastatic cancers, let's say this is an example from metastatic melanoma, with conventional treatment, just 15% of patients were alive at 36 months. But with these immune checkpoint inhibitors, you can expect 60% and more survival for long periods of time. And so I'd emphasize once more, oncologists, quite rightly, are going to continue to use these drugs. But with this comes a particular problem. These are adverse events, and you can see that there's actually quite a high incidence of gastrointestinal adverse events. There's a low incidence of myocarditis, very low. However, with that myocarditis comes a very, very significant, nearly 50% case fatality rate. So low incidence, but with a very, very important implication. And I'm just going to give you an illustrative history to give you an idea of the kinds of problems that cardiologists like myself running cardio-oncology services are facing. This is a 56-year-old, previously completely healthy woman who develops an unusual metastatic Merkel cell carcinoma. Initial chemotherapy did not control her disease, so she switched to a combination of immune checkpoint inhibition with these two drugs, and after the second cycle had relatively modest but symptoms she reported were fatigue, which is a very non-specific and common, but she had myalgia. She had soreness of the muscles, particularly around the hip and thighs. There was a mild transaminitis shown here by the ALT level, but a very significant rise in creatine kinase to over 10,000. But also you will notice the cardiac troponin T was very significantly elevated to 700, with our laboratory normal range being less than 14. And you can see here, I've plotted her troponins. This is over a 3-week period. These troponins are massively elevated, 1,600, up in the thousands. Initially treated with very high-dose steroids. We had to introduce also mycophenolate and subsequently tacrolimus before eventually the troponin falls. The take-home messages from this, for us locally, but also more generally, there is, and this is documented in the literature, a very significant risk of sudden death during this period of very high troponin acute myocarditis. The other thing that was very clear with this patient, there's really a paucity, a lack of many cardiac symptoms. You must remember that diagnosed, this condition will respond, but it requires high-dose steroids to do so. Just to follow up with this particular lady, 3 years on, 2021, her cancer as well is well controlled, in remission, and she doesn't have any cardiac symptoms. We have chosen to continue with beta blockade. No evidence, but I must say her condition worried us. This recognition has led to a number of suggested management plans, and this is one from a European group. So when clinically suspected immune checkpoint inhibition myocarditis is seen, the initial tests, patients who are unstable may go as far as endocardial biopsy to prove the diagnosis. In our service, we tend to rely mostly on non-invasive testing with MRI scanning, cardiac MRI scanning, which we find is a very sensitive and relatively, but not completely, relatively specific diagnostic tool for myocarditis. We may go on to biopsy if there's still doubt after MRI. So just to go back a little bit to summarize, the phenotypic expression of cardiotoxicity can be many and varied. Heart failure, which we could see with anthracyclines, with some of the alkylating agents, with HER2 therapies, classically trastuzumab and pertuzumab, and with the TKIs. Acute ischemia, coronary vasospasm with the fluoropyrimidines, and also platinum agents, which may produce a very long period of effect on the vascular tissues. Hypertension, myocarditis, and also more acute issues like hypertension and shock associated with the newer CAR T therapies, which I won't have time to address today. So facing this, there have been a number of schemes suggested in order to detect patients, to try and prevent problems occurring. And this is one of the schemes published some years ago by the American Heart Association. And it suggests here that in patients at high risk, you might want to discuss with the oncologists how the cardiotoxic formulation is going to be given, whether you can give anything to protect patients. I'm going to rely quite heavily on a recent publication by the European Society of Medical Oncology that brought together an expert panel, a consensus statement derived from experts from Europe, the USA, and from the UK. I think we start with the premise that patients who are going to have an anti-cancer treatment known to have the potential for cardiotoxicity are defined as stage A heart failure. That is, they're at risk of heart failure without overt structural heart disease or symptoms. And in this group, there is some trial evidence for all these groups, the ones you would expect: ACE inhibitors, MRAs, statins, antiplatelets, anticoagulants, beta blockers. And the topoisomerase inhibitor and chelator, or I should say binder and chelator, which I'll come back to, dexrazosane. And in these studies, there are a number of studies, what the consensus suggests that they offer evidence of a modest clinical benefit. The results are troubled by the fact that there's a very mixed population of cancer patients with very variable, sometimes very low actuarial cardiovascular risks, and very different cancer therapies and different definitions and trial endpoints. So although there's some evidence, it's not what I would call class A. And we need further studies to move this area forward. I'm just going to introduce this particular drug, dexrazosane. Dexrazosane is interesting because it binds to the 2-beta isoformal topoisomerase in cardiac muscles. It binds here and prevents anthracycline binding, and therefore reduces mitochondrial dysfunction, reduces all the ill effects associated with anthracycline binding. And the evidence, this was reviewed fairly recently, the evidence in children and adults of preventing cardiotoxicity without reducing, and this is the worry from the oncologists, without reducing anti-cancer efficacy and without increasing second malignancy, the evidence is now overwhelming. I would have to admit, however, that its use is not widespread in our community. So we can assume that the efficacy in preventing cardiotoxicity in children is also being approved in metastatic breast cancer in those individuals who are exposed to 300 milligram per meter square cumulative of doxorubicin or the equivalent. There is a challenge, however, that we see quite frequently in our clinics, and a patient who has a pre-existing cardiomyopathy from ischemia or a DCM, who then have a cancer and require anthracyclines to be treated adequately. And the data here is relatively modest, but it's suggested that you can give these people anthracyclines successfully, and it can actually help them get through their cancer therapy. So it's a reasonable strategy to address. We as cardiologists are very used to statins, and there's some evidence that hyperlipidemia in cancer exacerbates detrimental effects of inflammatory responses. There's some, although I have to say it's not strong, evidence that continuing statins benefits breast cancer patients, and there's some prospective evidence of protection, but you can see the size of these studies is small. So treating patients with cardiovascular risk factors seems appropriate, particularly if they're likely to survive their cancer and have extended life expectancies. I just want to briefly, just a couple of slides towards the end now, just say something for exercise. Exercise as an intervention has a really long history in cancer, going back to the original studies back in '86. And there's a whole timeline here of various different studies. And we know here from a study involving survivors of childhood Hodgkin's lymphoma that the incidence of cardiovascular events is very strongly related to their exercise habits. So the incidence of major cardiovascular events, shown here in panel A, is significantly lower if they exercise for a modest 9 Met-hours per week. And that compares to the group that does less exercise. And that's true for coronary disease, for heart failure, and also for valve disease. And there's a dose response. So the more exercise in Met-hours per week, the reduction in risk. I'm just going to focus for last few minutes on what we do having discovered cardiotoxicity. One of the issues is that definitions, the exact definitions of cardiotoxicity, have varied across time. Now, most groups would accept a 15% change from baseline if their ejection fraction remains above 50. This used to be 10%, but that's become a little bit more liberal. Or if the ejection fraction is under 40% when the patient is seen. We tend now to use the more sensitive and specific index of global longitudinal strain, or GLS, which hopefully prospective studies will show is an improvement on ejection fraction. A 12% relative reduction or 5% absolute reduction in GLS being sufficient to diagnose cardiotoxicity. If we include other components, such as vascular events, venous or arterial, rhythm disturbances, biomarkers, then the meaning and incidence of cardiotoxicity changes radically, and so does our approach to them clinically, let alone for studies. In summary, if an asymptomatic patient develops a significant reduction in ejection fraction, they are classified as stage B heart failure. That is, they deserve the specific heart failure therapies that we have an evidence base for. And to wait until there are clinical symptoms or evident heart failure gives your patient or condemns a patient to a worse outcome. And there is data, clinical, that in many instances introducing these therapies to stabilize the heart failure patient and possibly improve some of the reduction in heart failure can then allow the completion of their cancer therapy. And one of the things that should be remembered, interruption of a cancer therapy program carries with it a very adverse prognosis. So when do you intervene? Well, this is quite early data from Cardinale and her group in Milan, showing that here responders in terms of individuals who've had a fall in their ejection fraction as previously described, if you don't introduce heart failure medicines within 1 to 2 months, when you get 64% response rate, which falls to 0% if you wait for 6 months following the detection of impaired ventricular function. So starting early is crucially important for this group. So once heart failure is obvious and manifest, due to cardiotoxicity, we use conventional heart failure treatment, and there have been some prospective trials here. These are summarized. I don't expect you to see this table, but there are 16 studies here summarized relatively recently, but the numbers in each study are relatively small. The drugs that have been looked at are beta blockers, these 3, ACE inhibitors, a relatively narrow selection, ARBs, and spironolactone. So the summary from this particular review was that their use for secondary prevention in subclinical cardiotoxicity has to be individualized. So finally, to summarize, the consensus from the paper I've published in the annual Annals of Oncology by the ESMO group is this algorithm here, which I'm not going to go into. But I think, support that some areas of medicine, and this is a good example, are just too complex to rely on ad hoc methods and presentations to detect what are often low frequency but very high impact consequences, and consequences that may have decades of latency. So cardiology services need to adapt and develop formal systems, we call them cardio-oncology services, to undertake this work in close cooperation with our oncology colleagues and to participate in the research that will move the field forward. And meanwhile, before we have definitive prospective trials, we have to use the known remedies for our individuals at risk. This has to include risk factor control, exercise, and the appropriate medicines. And we have to introduce those early enough to make a difference. Thank you very much for listening.